Awesome. So that was a great talk. We're going to move on to our next one, which is going to be a sports toxicology talk, focusing on performance enhancing drugs and GLP-1 use in athletes by Dr. Mike Nelson. So I'll just take a second to introduce him, and I'll just remind people that you can submit questions into the chat afterwards that we'll get to after, just like we did for the previous talk. So for Dr. Mike Nelson, so he's an emergency medicine physician, medical toxicologist, and addiction medicine physician practicing at John H. Stroger Jr. Hospital of Cook County and Endeavor Health. He is a consultant for the Illinois Poison Control Center and is currently the program director of the Medical Toxicology Fellowship Program at the Toxicon Consortium, Cook County Health, University of Illinois of Chicago. Serves as the co-chair of the Medication Assisted Recovery Prescribing Practices Committee for the Illinois Opioid Advisory Council, and was a member of the HOPE Heroin and Opiate Prevention and Education Task Force for the DuPage County. He is clinical interest in emerging drugs of abuse, substance use disorders, and the use of athletic performance enhancing drugs. All right, so we'll move on to this talk, and I'll have Michael share his screen.
All right, everyone can see that and you can hear me okay? Good.
Yep, we can hear you.
All right, awesome. Thanks. All right. So first thing I always like to, when it comes to talking about performance enhancing drugs, is understanding the athlete mindset. And actually, what really got me interested in this was actually this article from Sports Illustrated back in 1997. I remember getting this magazine back in high school, and it was kind of the first time I really put this together in my head and got very interested in this. And this is right in the era of like steroid use in baseball, like Sosa, McGuire, Bonds, etc. And I remember this article coming out, bigger, stronger, faster. That was the first time I heard that coined use of that phrase. And obviously, as we know, it's part of like the Olympic kind of model, like higher, faster, etc. But within this article, it was very unique kind of thing about understanding the athlete mentality, particularly when it comes to performance enhancing substances. So they did a poll of about 198 sprinters, swimmers, powerlifters, all kind of Olympic level. And they asked them two questions. One, you won't be caught and you'll win. Would you take this substance? Of those 198 sprinters, 195 said yes, they absolutely would take that. And then they just kind of tweaked that scenario a little bit. You're going to get the substance. You got these two guarantees. You're going to win, and you'll win every competition for the next 5 years, and you won't get caught. But at the end of 5 years, you'll die from the side effects of the substance. Would you take it? More than half of those athletes still said yes. And it's so important to understand that mentality when it comes to athlete, that really the sport is their drug, particularly these high performance athletes. That is really what drives those dopamine reward pathways and gets them so excited and amped up that the sport comes above all else, above even their health. And they'll win at all costs because that is really their big motivator. And even buried within that article was this other great kind of saying that it's to be a great athlete today, you need a great coach, a great chemist, and a great lawyer. The so-called chemists, like what we call gurus, they're just likely to be trainers, doctors, or like self-taught drug experts. And that still rings true today, that everyone is still just looking for this small athletic advantage, whether it be supplements or even more illicit or illegal substances that do really put them at significant risks, or whether it be a nutrition or a training regimen, but everything is just gaining that athletic edge. And so when I was originally going to put this lecture together, I was kind of going through the usual anabolics, growth hormone, but I really got interested because of just everything that's on the news today about GLPs. I said, well, could this potentially be a future thing that we need to be concerned for in our athletes? And it's just been, as we've known, like all over the media, all over the news. You go online and there's things like it's kind of pop into your social media feeds that now essentially we can get these medications without going to a doctor. And in 2023, it was named the breakthrough drug of the year. So much so today now that 1 out of 8 adults are currently taking a GLP-1 drug. 1 out of 8, or 12% of our population. That's a huge number of individuals. And particularly a lot of people under age of 65 now are taking GLPs, particularly just for weight loss and not even for the initial indications of diabetes. A lot of people, about a fourth of people now are getting GLP-1s, not from their doctor. They're getting it from an online source, compounded pharmacies. And again, if anyone has paid attention to any of the social medias, I'm sure things popped into threads like about Hims and Hers and all these other kind of things that come in there where you can just fill out some surveys on a question. It gets shipped directly to your house. And you don't actually have to go to your doctor. You're not getting it for its original indications. Um, and a lot of people are getting these medications even though they can't afford it or they're having a hard time affording it because of the cost that's there. When we look at the mechanism of action, I find this very exciting as a toxicologist to look through all this. I know many of you do not, so I won't spend much time on this slide, but these are kind of the intricate pathways where your GLP-1s work. But to kind of make it a little bit simpler, your intrinsic natural GLPs are very short half-life, 1 to 2 minutes. And it really, our GLP-1 receptors are just on these major organs, your pancreas, the central nervous system, your GI tract, and the cardiovascular system. There is little to no effect directly at the skeletal muscle. And when we look at the pancreas, its main effect is to increase insulin secretion while decreasing glucagon. This has that net effect of essentially what we're seeing in our diabetics at decreasing hemoglobin A1C because we're increasing our glucose utilization and decreasing our peaks of glucose where that cell is more efficient. Interestingly enough, it also decreases beta cell apoptosis. So there's some gene transcription changes that occur that wind up helping long term for improvement in some of these diabetics. But our net effect is we decrease our postprandial and fasting glucose levels, which is, again, really one of the net beneficial effects that we're looking for. Our GI tract, it's delaying gastric emptying and leading to early satiety. This is the one I find fascinating. It's central nervous system effects. It works on like the nucleus tractus solitarius, the area postrema, and the hypothalamus of the brain, and particularly it increases that early satiety. So you're less likely to want to eat as large of a meal, and you don't have those hunger cravings. And this is really how it works on our dopamine reward pathways. So if you do eat, you don't get those food rewards. Like when I eat a nice piece of chocolate cake, where you're like, oh, that was delicious. I want to keep eating more and more. Where people just normally take a few bites and they're kind of like, I don't have that dopamine reward. I don't feel great about it anymore. So I'm less likely to eat as much. And that overall leads to decreased caloric intake. There's also some things about changes in sympathetic tone, necessarily at the muscle and the fat cells themselves over time, or increasing sympathetic tone. So you're a lot more likely to burn some of that fat. Interesting enough, this effect is all pharmacologic. There's zero physiologic effect. What that means is the more drug that's there, it has more of an effect. And the drug is way more potent than your endogenous GLP-1s. Again, that endogenous GLP is so fastly metabolized versus drugs are designed to last a lot longer in our system. But these things have been studied now for our substance abuse patient populations, gambling addictions, et cetera. And we're seeing that people that are on this are less likely to consume opioids or cocaine or alcohol. So very emerging field because of the way it works on those dopamine reward pathways that they just don't get that same positive reinforcement that occurs from the substance or the behavior that they're having. So very cool emerging potential field with that. And just kind of putting it all together, this is where we look at how it affects those organs that it affects. Our weight loss then is generally just from appetite suppression because of that caloric restriction, or the appetite suppression leading caloric restriction. There's no direct lipophilic or anabolic effects from our big one that we're using, semaglutide, but there is some stuff about additional or potentially other ones. And particularly that caloric deficit just leads to catabolism. You break down that fat tissue. Unfortunately, what we saw for a lot of these people, about 20 to 40% of that weight loss is actually lean muscle mass in our large studies of this drug initially rolled out. Much more than we'd expect with lifestyle weight loss. So if somebody was also just losing this weight on their own and doing it day to day with their natural caloric restriction, the GLP-1 use loss of lean muscle mass far outweighs that. And that's because it leads to the starvation physiology, whereas we're decreasing our caloric intake, we're burning that fat and that muscle tissue as well. And this unfortunately kind of leads to this negative vicious downward spiral where as we're losing weight, we're losing body mass, it's decreasing our mechanical load, which is less stimulus on our muscles to have muscle growth. We're not having that same amount of protein synthesis at the muscle anymore. So overall, people wind up having some decreased functionality over time. And the people particularly most at risk are older individuals, sedentary, or those that we have what we call sarcopenic obesity. And again, think about our typical patients that we've seen with that metabolic syndrome, where little overweight, kind of thin extremities, maybe not as much good at balance or standing, difficulty getting up and walking and turning. But a lot of these individuals are type 2 diabetics and were put on these GLP-1s. And unfortunately, we wind up seeing a lot of muscle loss in those individuals. And it kind of intertwined all together where they have this muscle wasting effect. And again, that's really what sparked my interest is seeing this and looking about the GLP-1s and this muscle loss that was occurring in these individuals. Particularly so that a lot of societies, et cetera, are trying to distinguish sarcopenic diabetes as its own special entity because they have this altered body composition, this higher adiposity, decreased functionality. And we know these lifestyle changes overall lead to inflammation, oxidative stress. And we've seen that about almost 3 out of 10, somewhere around 1 out of 3 to 1 out of 4 individuals that are these type 2 diabetics actually have this condition, the sarcopenic diabetes. Over 60% of our diabetic individuals are at risk for developing this during their lifetime. And this is kind of that intertwining effect of how that occurs, that obesity, lifestyle issues, hyperglycemia, and all their comorbid conditions lead to that decreased functionality and decreased muscle stimulus, which then leads to the sarcopenia. And we know that these individuals have worse clinical outcomes, higher risk for fractures, osteoporosis, longer hospital stays, et cetera. So then we add semaglutide onto that, and we're kind of looking at those individuals. So this is a great study in terms of 220 individuals and about 212 controls, all elderly over the age of 65, type 2 diabetics. Same right on point with that sarcopenic prevalence, 27.7%. Really broke it down between men, women, those that got it, didn't get it. And essentially over time, they showed decreased hand grip strength, decreased skeletal muscle index, and decreased gait speed. And we wind up seeing right initially, a lot of these individuals might have had slight improvements in that because they're losing some of their adiposity. So overall, their weight's down and their muscle appears to be function. But because of that calorie restriction over time, they start breaking down those muscle tissues. So we see by 12 months to 24 months, a lot of these people's skeletal muscle index all go down. Their hand grip strength starts to decrease. And that's where you see, like, for instance, on the bottom 2 graphs, the blue line and the purple line, you show the hand grip strength versus controls go down, as well as their gait speed starts to decrease as well. So overall, progressive loss of skeletal muscle, functional decline that occurs on these individuals. And well, how do we combat that? Well, naturally, we think about exercise. If we do a very targeted, systematic approach to these individuals, this is a great systematic review of 42 randomized controlled studies, over 3,000 adults with sarcopenia, all older. And they started adding resistance training at least 2 times per week, doing balance functionality, and just doing those 2 things alone improve their gait speed and their time to get up and go test where you stand up, walk 3 meters, turn around, walk back in terms of that checking time. And if we add nutrition, particularly 1.2 to about 1.6 grams per kilogram of protein to their diet, that wind up improving their grip and their chair stand strength. And that was just with your sarcopenic adults. So we know that exercise combats that sarcopenia, and it needs to be over months of duration. And again, it's the easy thing that we'll always say in medicine, diet and exercise, but we know it's so hard to implement for individuals in terms of lifestyle changes that occur. So what do we do next? Well, we take our drug, our liraglutide, and we take our exercise things, and we want to study these in animals. This is an amazing study that they did in rats, and they were looking at middle-aged rats versus young rats. And this is, I didn't know this, but rats middle-aged are 16 months old. Young rats are only 3 to 4 months old. And they had a liraglutide and they did an exercise regimen. And how they studied these rats out, they had them climb up a 110 centimeter ladder, 80% incline, and they started to add a progressive weight to their tail. And they would check the amount of time that they would do. And they had a control just getting liraglutide, and they had controls just doing exercise. And what they wound up showing is that you did liraglutide with exercise, that it preserved their muscle mass. It actually had decreased antioxidant defenses, and it changed their lipogenic gene expression, which is really neat that actually these individuals that while they were getting their GLP-1, that over time, if they were to come off their GLP-1s, that they would actually have less propensity to developing the adiposity after. Because again, if we go back and look at some of those initial studies, once people stopped their GLP-1s, they started gaining that fat back almost immediately afterwards. So then this started spurring a lot of recent studies, or if we're looking at it, where all the literature is talking about muscle health and kind of combining our incretins, all the muscle loss in GLP-1s, and all these kind of studies are in the past 3, 4 months, where a lot of the literature is really focusing on how do we balance preserving our muscle mass and losing weight at the same time. And you can just see there's a dearth of kind of large studies that are there. But essentially, all of those take to the point where if we take exercise with our GLP-1s, we will preserve our lean muscle mass that's out there, which makes inherent sense. And this is really the only study that is looking at particularly our younger individuals. So this was a study in China looking at 43 patients, all around the average age of about 30 years old. So really kind of getting to our targeted patient population. They did 6 months of a retrospective analysis of 6 months of study, and they did semaglutide in its typical escalating dose, like 0.25 milligrams weekly up to 1 milligram. All these people had a nutritionist that was involved and only kind of lowering their caloric intake by 500 kilocalories per day, and was kind of doing targeted exercise with resistance and aerobic, a minimum of 150 minutes weekly. And when they wind up showing is that all these people lost their weight, about 11% or 10 kilograms of their body weight, and very little to no change in their skeletal muscle index. It didn't change muscle mass, it didn't change grip strength, calf size, all preserved as well. And then from there, there's been additional studies that are kind of coming out, and that a lot of these GLP-1s actually can increase testosterone in these individuals. So this was looking at over 1,000 articles. Only 4 really good studies were looking at biomarkers in this in younger individuals, and most of them were liraglutide. Liraglutide has a less potent effect than semaglutide, and wound up showing that essentially with liraglutide, there's an increase in total and bioavailable testosterone. There's no change whatsoever in free testosterone. So its clinical effect is unclear at this point in time. But just a really well done study where essentially they were eliminating confounders from each other study that was there, but it's reproducible time and time again that the testosterone levels are actually going up. And if we kind of spin that a little bit further, tirzepatide is also one of our GLP-1s. It has a combined glucose-dependent insulinotropic polypeptide effect, which actually can potentially have some anabolic effects where you increase that glucose utilization of the cell and increase development of muscle growth. When you kind of use this one, there's combined preserved skeletal lean muscle mass. So a lot of the emerging evidence, there's a phase 2B drug clinical study, this one called bimagrumab, which is a monoclonal antibody, particularly at blocking activin receptors, which winds up leading to an anabolic growth effect. So this is just on the horizon of what we're seeing. So this really got me saying, what are we potentially looking for in the future? And that when we look at the World Anti-Doping Association, really they're looking at this as well. It's currently on the list of things to be investigated, and they're monitoring for this. So they're looking in athletes' biologic passport in terms of the metabolites of semaglutide and liraglutide. Right now, there isn't enough data that's out there. However, when I'm looking at this data and as the growth of it, as I really dove into this, the past few months, there's just been an explosion about preserving muscle mass and muscle growth that our gurus that are acting with a lot of our sports medicine trainers are like, look, currently it's not banned. If I can maintain my muscle mass and muscle growth and I decrease my fat tissue, I'm having improvements in my weight to muscle strength functionality. Could this potentially be beneficial in my weight sensitive sports? So think about things like cycling, figure skating, etc., where I have that same amount of power, but I'm just dropping a little bit of weight, and that power to weight ratio is shifted. So, and for us, things are banned by the World Anti-Doping Association. If there's a potential to enhance your sports and performance, it poses a risk to the athlete. In the world of toxicology, everything poses a risk. There is no safe substance, right? These things have only been around for a decade. We don't know what the long-term risks or side effects yet are out there. And if it violates the spirit of sport, if we're trying to get that athletic advantage, if we have two of those three combinations, it would be banned by the World Anti-Doping Association. And these are just the major risks with the GLP-1s. Big ones, the GI stuff, 20 to 40%, which many people in the world of sports think, well, if people are having these GI side effects, the athletes are less likely because their training might not be as effective to have this. But again, like steroids and everything else, if you can use that, drop your weight, get to the same amount of muscle preservation during your training period and get off the substance when you're in competition, would that potentially be beneficial? There's a lot of concern in that realm. Fatigue is mostly thought to be to the caloric restriction. And interestingly enough, there's some stuff about potentially causing ischemic retinopathy. So important to know that. We don't know the exact numbers on there, but there is an association. So our big take homes are these GLP-1s really reduce our caloric intake. There's no direct muscle effect. We know our older individuals are at risk for this muscle loss, but it can be combated with that higher protein diet and by combining exercise, balance, and aerobic training. So when we think about our athlete, though, we know they're completely different. They're not older, they're not obese, they're always training, and that's part of what gets them there. They don't think about food as a reward. They're thinking about it as fuel. So they're inherently are different for that at risk for developing that sarcopenia because these are just naturally ingrained into their training regimens. So that if there's anything that they're going to reduce just even slight amount of caloric intake to drop that adiposity, that this potentially could be on that fuel or on that future horizon for abuse in our sport. There is zero studies out there right now, specifically in this patient population, but it is being investigated, and I think we're going to see a lot more over the coming year or two, just because of the ubiquitous of these out there and the amount of media that is out there on this medication. So, good questions. Okay. Thank you very much.
Yeah, just looking through the chat. I don't think we have any specific questions after that talk, but it was a great and very informative talk. I know just one personal question here from some athletes we've seen who may be on these GLP-1s. You kind of touched on it a little bit with this fatigue that they feel, but have you seen any of the literature support any sort of like increase in tendinopathies or tendon issues? Because some patients do kind of complain about that, and it could just be that they're more sensitive to it. Maybe they're more fatigued. But wondering if you've seen anything in the literature about that.
No, not about developing like tendon rupture issues. A lot of the stuff they were thinking was because of alterations in body compositions that occur so quickly that it changes like the muscular load, which then leads to tendinitis or tendinopathies, but not like a direct tendon related effect, like potentially with fluoroquinolones or et cetera. other types of medications or substances that are out there. And again, just kind of that change in mechanical load on the body, because the effect on body composition is so rapid with these because of the massive reduction of calories that people take in. Again, I think a lot of those initial studies about that are completely biased because of the patient population. You're looking at these older individuals that were already sarcopenic to begin with, and they already have sedentary lifestyles, so they're extreme at risk for developing that. So just as we've seen this explosion over the past 2-3 years of younger individuals using this, it's too new to really know long term what the effects are going to be. But I have a feeling we're going to see a lot of it in our clinical practice.
Awesome. Thank you very much.
Cool. Thank you.